If someone can message me when you see her. Mhm. Hi, everyone. If you're just joining us, we're going to get started in just a moment. I'm just still letting a few people in. Okay, I'm going to get us started. I see a few people still joining, but we will kick it off. So welcome everybody to our third session of our Nurse-Led Care Learning Collaborative. Today, we are going to be talking about leveraging program data and using electronic medical records to demonstrate the impact of nursing. My name is Kate Gleason-Bachman. I'm with the National Healthcare for the Homeless Council, and I'm going to just get us started for today. If this is your first time joining us, welcome. We'll have a few little introductory slides in just a moment. So we're very excited to bring you this content today. I think it's going to build upon what we talked about last time. We really had some wonderful speakers and a great discussion afterwards. So we're hoping to do something similar today. We'll be hearing from a couple speakers, and then we will have some time for discussion. Next slide, please. Just want to go over this quick disclaimer. This learning collaborative is supported by the Health Resources and Services Administration. However, it does not necessarily represent the official views of nor an endorsement by HRSA, HHS, or the US government. Next slide, please. As I mentioned, I'm from the National Healthcare for the Homeless Council. My colleague Katie is here, and we are also partnering to create this learning collaborative with the National Nurse-Led Care Consortium. We have worked to bring this to you all together, and they are a wonderful partner. And we're very happy to also have faculty joining us. So these are folks who are joining from organizations across the 4 sessions, and they are coming from Circle the City in Phoenix, Arizona, and Colorado Coalition for the Homeless in Denver, Colorado. Next slide, please. Just a quick review of our learning collaborative. This is an interactive and participatory learning space. It's meant to be a community to provide resources and also the ability to interact with experts from the field and with peers. We really want people to be engaged. We are asking people to attend over all 4 sessions, or at least have someone from your organization attending. And so we really want this to be something you get something out of, and where you can have your questions answered and have some things to take away. Next slide, please. We're very happy to offer nurse continuing ed credits. This is possible through the National Nurse-Led Care Consortium. So in order to get the credit, it's 1 contact hour per session. You need to participate in the entire activity, complete the session evaluation, and also get an 80% pass rate on the knowledge gain assessment following the session. So the poll will pop up at the end. That's the evaluation. And then in the chat, we'll drop the link for the assessment. I think last time there was an issue with the link. I don't think it came through. So this time, hopefully it will. We can also send it as an email as we did last time if folks have a hard time accessing it. Next slide, please. So as I mentioned, this is our 3rd session, 3rd of 4, and we'll be talking about using data and EMRs to demonstrate the impact of nursing. Next slide, please. Okay, and with that, I'm going to pass it over to my colleague so we can learn a little bit about who's here in the room.
Thanks, everyone. Great to be with you again. I am hopeful that this will come through. Give me 1 second while I drop the link in the chat for the direct Mentimeter. I'm going to try and go back 1 slide. I think that it's the QR code that is not appearing. So apologies for that. Oh, here we go. So hopefully that QR code will work. In the chat should be the direct link for the website, and then also menti.com and that 8-digit password. we'll get going. Hopefully you are all familiar with this. This is just a chance to hear from you all. Also, feel free, for those of you who are unable, by all means, use the chat. You guys have been such a great group in terms of engaging with the chat and answers and questions throughout the session. Please, we welcome that. And we have our wonderful faculty here that as we get to the content section, that anyone who feels comfortable answering a question will certainly address it. And but we might pull things into the Q&A at the end. So with that, first couple slides are ones that you've seen before: names, pronouns, organization, titles, roles. Helpful for us to know who's here. Again, we welcome in the chat. Wonderful. Seattle, circle the cities in Phoenix, got Montana. Oh, exciting. Oregon. Great West Coast representation. Portland, I'm not sure if that's Maine or Oregon. Chicago, Milwaukee, Pueblo, Colorado, Seattle. We have our wonderful staff from the council. Hannah, we're so lucky to have her as our intern this year. Kansas, Cleveland, Ohio. Wonderful. This is great. Excellent. In the interest of time, I want to give, I know it's a lot to type, so I don't want to rush too far. Great. Georgia, Illinois, Portland, Oregon. Thank you for clarifying, Kim. We welcome all Portlands. We'll move on to the next one. This is a fun way for us to just kind of see the spread of where everyone is in the country right now. Excellent. Really nice array across the country. Thanks, everyone. And then we have, I think, just 2 follow-up questions. Really helpful to us. I know we asked this as part of your application, but really helpful for the faculty to know and for the presenters today just to know who's in the room right now. So does your organization have a nurse-led team or program? Oh, what a nice disbursement across kind of the continuum, which is exactly why we realize this is such a great learning opportunity for all of us, because there are programs at various different points along this road and doing different things. So there's some who are in process of building or maybe expanding. We know that some have had pilots. I should have probably added another option of had one, but not right now. That could be due to staffing, due to funding. There are various different reasons that programs have to change in terms of their operation schedule. We know that those can be challenges. So feel free, if that is the case in your organization, that is certainly an understandable one. And hopefully it means that you're here and ready to, when the opportunity arises again, to get back to having a nurse-led program. To springboard us into our topic, how aware of you are, how aware, excuse me, are you of your organization's use of codes? Apologies for that typo. Kate and I were talking how in our work, a lot of times it is, I don't know exactly why I do this. I just know that I have to put in this code with this order. She as a nurse, myself as a social worker, we have things, a lot of times it was just how we were taught. And so you have to hope that you were taught correctly, because that is certainly part of it. So it sounds like this group has a good basis. Many feel some knowledge of codes, doing just what you're told. I certainly can empathize in that camp. And knowing nothing. I think that this is very often, depending on how it appears in your medical records, you might not even know that there's a code associated with what you are clicking. It might happen entirely on the backside. So really appreciate all of that, and that'll give us an opportunity. I'm going to hand it over to Emma from High Tech, and thank you so much for being with us, Emma. The floor is yours.
Thanks so much. I really appreciate the opportunity and invitation to be here. My name is Emma Ansara, and I'm a clinical advisor, and I work at JSI, and I support the High Tech project. So let's go to the next slide. Just before we jump into content, just a brief overview of High Tech. Like NCHC and NNLC, we are also an NTAP with another acronym, so National Training and Technical Assistance Partner. That means that in our role, we partner with HCCNs, primary care associations, and other NTAPs, as we are doing today. This slide just is a brief overview of kind of our common offerings. Maybe you've heard of us before. If you haven't, we would encourage you to visit the national website. There's a tremendous sort of range of resources, also a calendar of events. We do learning collaboratives too, and remote trainings and technical assistance about specific topics. And you can see a lot of those topics on the right hand of the screen. As with our other NTAP organizations, while we do receive support from HRSA, we cannot and do not speak on behalf of HRSA or the Bureau of Primary Healthcare. So let's get into it. Next slide. Just before we get going, a little, maybe an apology in advance. I am a nurse and a family nurse practitioner, but I'm also a doctoral student in the social sciences, and I have an emphasis on medical anthropology. And my research is actually focused on making the work of care delivery visible. And so I was really appreciated the opportunity to sort of talk on this topic. So a heads up, there's going to be like a little theory that starts us off, and then we'll get into a more sort of pragmatic content. And if I, for any reason, don't get there, please let me know. In the spirit of making things visible, I do want to recognize sort of contributions from some colleagues who are not with me today, but they are in spirit. So Jillian Massini and Jerry Lassa, I have so much appreciation to them for their contribution to this content, and also to my colleagues in general who sort of support my ongoing learning in this area and so many others. All right, next slide. So there are, when I think about this presentation, sort of two themes that I'm going to kind of come back to as I move through the slides. And so one is this idea of sort of visibility, really working with data and through technology to make the nurse role more visible. And then also thinking about the interconnectedness of the nurse role, of really all of our roles within a health center or program. And so really what opportunities are there to sort of strengthen and better integrate that nurse role through data and technology with the work of others, and really what that impact is on quality outcomes. All right, next slide. Here's the theory part, just roll with it. So, nursing work has a lot of features that make visibility problematic. So it's historically work that was done by women, and so falls into a category of work that is often assumed to rest on the natural talents of women. It is also body work, so in that work can require transgression of sort of normal social boundaries. And so it's something that actually often it doesn't feel comfortable, or there are taboos about talking about it. There's also a way in which the work of nurses is extraordinarily diverse. And this actually is something that contributes to its invisibility, or at least to invisibility of certain elements of nurse work. And also nurses are doing work and working in a field where there's a continual rate of change. I mean, that is true for healthcare overall. And again, that's another quality that can impact visibility or invisibility of work. Next slide. There's also a way in which, sort of layered on that sort of history of nursing, kind of the reality of the practice of nursing, there's ways in which nurse work and sort of technology interact And ways in which the work that is done through technology may be more or less visible. And so it's very likely, and I think you can probably think of this, there's specific knowledge and skills and tasks that really aren't necessarily recognized or remain hidden in technology. If you feel so bold as you want to come off mute or type into the chat and sort of think about a way in which working through or with technology makes work less visible, I would welcome that. But in the absence of that, I'll offer you my own example, which is to just think about whether it's, orders that are entered into the EHR by nursing staff, whether that may be refills or orders for diagnostics or screening tests, or when, nurses are involved in rooming patients and identifying what their reason for visit is and doing that initial, rooming process. Those activities often are sort of, they're often documented within an EHR and kind of given ownership to other members of the provider team. Kara has been so kind as to jump in on the chat. Thank you. And sort of say, right, there's ways in which checking boxes is sort of a reduction of those like complex decisions that people are making. And so that kind of reduces what is a full narrative between a nurse and a patient, between us and a patient, to a sort of very small amount, kind of obscures some of that complexity. Cricket is kind enough to talk about sort of the electronic submission, really, right, all of that sort of documentation that leads up to prior authorizations, nursing assessments, right, get folded into the provider visits, right, and there's just a way that EHRs in general, like, do reduce the complexity, and I think oftentimes the nuance and like the wholeness of a person as we're working in that space. Thank you guys all so much for contributing. Let's go to the next slide. And so kind of in the spirit of trying to make nurse work visible, I'm going to really set out some concepts that are related to data in the health center setting, and really invite your observations, your reflections. You've always already doing this so well about opportunities for nurse work to become more visible. And though even recognizing it's diverse and, we can set that aspiration out for ourselves, but we may not achieve it. We'll try to move the needle a little bit. And so I'm going to start with the idea of data governance. So this is the set of rules that govern the use of our data and system, or really very practically what we document, where and why. I think we're increasingly hearing this term data governance. And while we may be less familiar with these other terms, I bet you're familiar with the activities they describe. Data stewardship is the commitment to work that folks undertake every day to record and maintain data so it's accessible, it's usable, it's safe, it's trusted. In other words, sort of what is our individual and collective responsibility for creating and maintaining a quality data set? And lastly, this notion of the data life cycle, and this is the way in which information or data sort of travels through our work and is used after it's recorded and becomes something of significance, and really how this data that, we've decided how it's going to be collected and where we've done this really, good job at collecting it, being consistent and, do that sort of in a consistent manner to our colleagues. Really, this is when it gets put to use. Next slide. So, and it's really helpful to think about data governance, stewardship, and life cycle sort of happening within this larger data ecosystem that is occurring within the health center, and realizing that data is sort of cutting across numerous sort of functional areas. So the day-to-day operation, clinical work, finance, and also IT. Next slide. Another way to sort of think about kind of data, this data ecosystem, is really thinking about this from a kind of functional perspective. And so we really think about the connection between data governance, stewardship, and life cycle as sort of what's happening in clinical spaces, and then sort of what's happening more behind the scenes. So really in those clinical spaces on the front end, this is really where health, and again, you all know this, I'm just sort of adding some like layer and nuance to this understanding and sort of thinking about this idea of interconnectedness and maybe what we see on a daily basis, but maybe we don't. And also the areas of data support that we don't see. Really, front end is where we're collecting data within the clinical environment. And that really counts and sort of is built upon a lot of activities that are happening sort of in the background, but that are very integral to our ability to do that in a safe way, a secure way, and really to also aggregate that data so that we can utilize that data in an aggregate form, right? The data that we're seeing on the front end when we're actually entering data into the EHR is data that we can sort of take action to and respond to in that moment, respond to the needs of a patient, especially as we sort of pass care across the team, we pass that baton. But really when we think about, we can aggregate this, we can look at this data longitudinally or over time, right? That's a lot of the back-end functionality. And these two things are really integrally linked. And really we want to be utilizing all of these functions. But sometimes, depending upon what our roles and responsibilities are in the day-to-day, we may be more engaged with one piece and sort of lose sight of that larger, the way in which that work is interconnected and also really dependent on one another. Next slide. And so really when we're thinking about this data ecosystem, this data governance, stewardship, and life cycle, we're really sort of taking into consideration this sort of very fundamental triad, which is the people, process, and technology really together create a system where patient data can be accurate, it can be secure, and then it can be used to the best ability, or to greatest service of our patients individually, in the aggregate, and then maybe also regionally, locally, or nationally. So people are the users, they're us, right? Healthcare staff, those are the folks that are often operating both on the front end and the back end who sort of enter, access, and manage data and do what is needed to make sure that it's sort of followed, it's secure, it's up to date. Process is often sort of the rules and the steps that are decided upon and then really implemented to help to sort of collect and manage that data responsibly. This is sort of the workflows is another word to think about that. And processes are really built into data governance in which there are, standards that are set for data capture and use. And then also kind of these processes help us to kind of ensure that data is recorded in a consistent and safe way, and really also dictate sort of how we document and how we handle data properly, which in turn will support sort of reliable and high quality care. Technology is the EHR and also the other systems that we use to store and protect and analyze data. And at this point, we know that in most sort of clinical settings, there's numerous layers to that technology, and it doesn't always work well with each other. It is its own complex ecosystem. So really, it's all of these things that are working together. And sometimes we tend to overly engage with one sort of leg of this stool or one corner of this triad rather than really equally investing in all. And sometimes looking through these lenses can help us figure out maybe where we need to shore up that stool or the work. Next slide. And so really understanding what nurses do each day, what nurses record, how the information is used, and how people, processes, and technology connect at each step, this is really what can help us improve our work. And really that's within our own workflows and in our work with others. Really that collaboration can really significantly impact how the information both kind of goes in the front end and out the back end. And by knowing really how these actions affect our organization that we work in, we really can better support things like quality measures, responding to patient needs, and overall performance. Okay, next slide. So I hope you're still with me and you're starting to sort of see data. There's a couple things that I'm hoping. One is that you're sort of starting to think about data in this sort of complex and three-dimensional network, and that we're also starting to have some common language that can support a sort of more robust engagement, especially for nurses. So better that reflection and also their contribution to the way in which this data is functioning within this complex landscape. I'm going to turn a little bit as promised and move to kind of some more kind of practical considerations and implementation opportunities that kind of arise out of thinking about this. So next slide. So historically, and I think this started to come out right in the comments, Kate mentioned this, which is historically within the electronic health record, nursing documentation like nurse notes are something that is kept separate. And when we look across different platforms, whether that's like in outpatient ambulatory care settings or inpatient, we've really seen a historical separation. As we talked about before, I think EHRs are set up to often kind of categorize and separate data, and there's reasons, some of which may be good for doing that. But that's meant that there's a kind of invisibility. And so I wanted to sort of both recognize that and also recognize that nurse work, however, is often documented in a variety of places within the EHR. So whether that's templates and modules or tabs, whatever environment you're in. And so we can just think of that in terms of, we know that nurses are documenting within care management modules. We know that, as we've talked, as other folks have shared, they're documenting, within the history of present illness, as if it's a part of an office visit. They're documenting responding to, screening results, or, in a triage template. So there's lots of places, even though formally nurse documentation may be something that's separate, we also know that nurses are documenting in a lot of the different places in the EHR. Next slide. There are sort of best practices for really thinking about integrating nurse work into the EHR. And I would be remiss if I didn't suggest that this is true for nurses. This is also true for CHWs. This can also be true for behavioral health professionals, but they're just sort of some concepts to think about. And so one is really the utilization of standardized sort of nurse activity assessment tools and billing codes. And that was so effectively and well covered in the session from last week. Really thinking about training and what training in the EHR or use of other platforms and technologies is specific to the nurse role, and how do they need to be kept aware of guidelines and upgrades that may be specific to their work. Really thinking about an environment which supports nurses and feeling comfortable at communicating with colleagues through the EHR. And this actually came up a little bit in last week's session, where one of the presenters said it was kind of a leap to feel comfortable to document within an office visit note. Thinking about integrating documentation of nurse activities. So what opportunities are there to sort of not keep that sort of nurse documentation separate, even though there's these historical structures? And then really thinking about education of the nurse role across the healthcare team and how that shows up in documentation. Next slide. And so really, what do these recommendations look like? And a lot of it is around the development of processes and workflows, and then training that's related to support those commitments. And again, in this table, I've just tried to surface a few sort of best practices that we are aware of, through our work at High Tech, whether that may be, right, example documentation models, asynchronous training opportunities, and also getting into conversations about data governance and thinking about nurse involvement in data governance, and then also analysis and sort of data outputs. Next slide. And so I thought it might be helpful to sort of put these higher level concepts into just a case scenario, but I do also want to recognize that there's another question that's come into the chat, and it sounds like that's more of a peer question. So if it's okay, Shamika, we will make sure to sort of tackle that at the end of the didactic presentations. All right, let's go to the next slide. So for this example, I wanted to consider a scenario where there is a nurse on the street medicine team who conducts a PHQ-9, so a depression screening for a client during a sort of routine contact visit, and goes on to record that score in the electronic health record. One of the first questions that I have is really, what guidance is there about when and how to document that response? And is there agreement on where that should be documented and why? So that's a good prompt to sort of think about that kind of upstream work. A second question is, what happens once that information is documented? What happens when the PHQ-9 score or the response to individual questions are documented within the EHR? And really, how you answer those questions, how you collectively answer those questions, has a significant influence on both the impact that the data can have on sort of patient care, but also the work that nurses are doing, or that nurse on the street medicine team is. In terms of impact, really, the recorded score can help identify clients that are at risk for depression, and that can sort of help the clinic or the team respond, as they should, and sort of respond quickly to individual needs. But also in aggregate, that data can be used to track mental health trends for that individual patient and or consumer, and then also that can be used in aggregate, so with other patient information, to sort of track mental health trends, on that team. And really overall, that data is used to inform things like quality measures, such as those related to depression screening and depression remission. But also it can be used with other patient information to look across, are there certain groups or segments of the population, whether that is related to race, ethnicity, socioeconomic status, insurance status, and then you can start to kind of have a complex sort of more nuanced understanding of kind of what are ways to maybe better address, inequities in care, and sort of what opportunities there are. Next slide. So again, if we look at this case example through these examples of data governance, stewardship, and life cycle, we can start again, hopefully, to kind of, connect actual real life experience with this sort of framework. So in data governance, really, that's these sort of upstream decisions that I kind of referred to or prompted you to consider, prior to the data being collected, what are the expectations about how that data is documented, and what happens depending upon what the scores may be. Is it attached to a visit? All this, is it a scanned document? Is it something that's done right in the EHR itself? In terms of data stewardship, this is really the sort of, action that this individual nurse can take to kind of conform to the expectations of data collection, of the quality of the data, and then use it, in response to, but also, use that to sort of consider quality, has that data been consistently collected in the same way for all patients? And again, if there were a case in which, a sort of separate or later review of that data suggested that there were elements that were missing, actions that weren't taken, again, that's an opportunity for feedback about, potentially improving that process of depression screening for the street medicine team. In terms of data lifecycle, right, we sort of talked a little bit about capture. There's also sort of storage. How is that being securely stored, so that it could be accessed in the future? Also, who has access to that information? Is, information about depression screening something that's accessible to all team members, to, a subset of team members? And then, as I've sort of suggested before, the PHQ-9 scores from many patients on the street medicine, who are seen through street medicine, could be used in aggregate to inform, really, support ideas of like trends across that program. And this could help, help teams and organizations consider sort of where resources should be driven, what skills may be needed to respond effectively from the team, and many other decisions. Next slide. And so potential outputs from this example are decisions regarding patient care, right, in responding to that individual patient care, and that can include treatment planning for that individual, but also care linkages. There could be reports, right, sort of based on the aggregation of that information, as screening numbers, and that those can be made to the state, but also to sort of federal entities. If I think about your UDS reporting, for instance. And then there are also, as I've suggested, analysis of the screening data, which really can help to determine, allocation of health center and program resources, additional trainings, if looking across the street medicine, there were lots of people who, scored on their PHQ-9 and said that they had, suicidal ideation, maybe really making sure that that team is equipped to respond confidently and effectively to patients' concerns and thoughts about suicide. Next slide. So we're getting to the end of my section, I promise. So one is, and I wanted, so again, that case example, we can sort of look across, you know, the data governance, stewardship, and in life cycle. I wanted to take a sort of, I think there's a sort of intuitive understanding of kind of, or not intuitive. I think there's, you're able to grasp, I think, if you're involved in the operational sort of day-to-day clinical concerns of a program, you know, you're able to understand sort of that data stewardship role. I wanted to talk a little bit more about nurse involvement and data governance and data lifecycle to sort of take us out. That's sort of where I wanted to end, just to kind of hopefully expand the idea of sort of where nurses can be sort of visible and also have impact on data and work in the health center overall. And so, you know, one of that is to really think about data governance. I mean, you know, and sort of how data governance committees come into being and sort of what roles or opportunities there are for nurses. So data governance committees, and honestly, like they rarely start out as data governance committees. Usually it's a group of people that are convened to sort of tackle a particular challenge or problem. And then over time, their function grows. And so given the organic sort of nature of that development, there isn't always a sort of intentionality about composition and representation. And I think that's really reasonable. I think it's very reasonable to sort of start small. That's actually kind of one of my, you know, tenets of work in an operationally complex environment like a health center program. And I definitely don't think there needs to be a dynamic in which, you know, there's a data governance committee and we're sort of making up work for them to do. But oftentimes these groups start where there's been an area where it's hard to achieve quality outcomes, hard to achieve the sort of goals that were originally, you know, committed to, or maybe we aspire to. And so topics that kind of come up over time is that, you know, who's the group that's deciding like how to allocate sort of scarce resources for analytics, for setting priorities, and really communicating those priorities to staff. You know, who is the group that's sort of organizing and resourcing, you know, data in its relationship to quality improvement projects? Who's the group that's sort of thinking about aligning data strategy with organizational strategy and then monitoring that progress over time? Who's the group that decides what are all the changes that we can make in an EHR? We know that there's often lots of requests that come in from staff, but how do we decide who's going to do that? And in one case, Jerry said, the way that I think of a data governance committee is the Supreme Court of data-related decisions within you know, an organization or a team. All right, next slide. And so really, what, you know, the question that I have for you, and I encourage you to kind of reflect, is sort of how might nurse involvement in data governance, like what could that look like? And also potentially how could that enhance patient care? I think this is really where some of those ideas of visibility come in, really, because without nurse involvement in a data governance committee, we really only have partial representation of how the work is done. And here's an example that comes to mind. But again, I invite your own thoughts and reflections. Just recently, I was supporting a team that was transitioning sort of telehealth primary care provision for Ryan White patients, so individuals who are living with AIDS. And this team decided that to support telehealth sign-on, they were going to make a push to get patients signed up for the patient portal. So the nurse educator sat through many, many visits with patients, really helping them to sign on to the portal. And what he found was the biggest hurdle to portal sign-on, and really for those who were kind of late adopters of using the portal, was password management and email sign-on. And also that the clinic sort of did business under a different name than was available in the dropdown for the portal sign up. Prior to these conversations, the lack of telehealth engagement from patients was considered a preference. And so again, I think there's this really incredible way that this nurse experience, when brought to the light, very much changed our conception, our understanding, and also contributed to the collection of data metrics. So there started to be like, we're not going to just look at who's enrolled in the portal. We're going to look at who's enrolled in the portal and who's utilizing that portal frequency. And we're also going to look at what elements of the portal are they using to help guide information about further support and sign-on. So really, the work was understood in a deeply different way. I don't know if there's any examples that you have, but I hope I'm sort of getting your wheels turning. As promised, I wanted to just leave us on sort of thinking about the data life cycle and really opportunities for nurses to be involved in the data life cycle. And really that sort of connecting some of those behind the scenes. Thank you so much. I forgot to ask about moving the slides ahead. You know, and I want to emphasize, so I think through, you know, the example that we had before, we talked about sort of data generation, right? That aspect and nurses' involvement in that. I think the thing I want to kind of elevate or encourage is really thinking about, you know, to what extent is two questions. Is nurse work represented in quality metrics? Are there data that's being reported out that both represents, you know, work from nurses that's integrated across teams, but also is representing the ways that nurses, perhaps there are quality metrics that are specifically sort of related to nurse activities. And so again, we can go back to that example before of the nurse educator, you know, really thinking about reporting out on increased portal use or telehealth use through the portal, if we know that that's really related to, you know, nurse educator activities. And then another question is, when you look across sort of those data quality metrics, the data analysis, the data aggregation, are priorities that nurses have in sort of thinking about the well-being and care of patients being reflected within those data metrics. And that gets, I think a lot that very many times, and this is sort of could be a whole nother conversation, is that data quality is something that like kind of externally drive, you know, is like an external force, but I think it's actually really important that health, you know, healthcare, you know, health centers and health center programs really think about kind of what their internal drivers are for quality. What are the priorities that they have? And so within sort of that orientation, you know, thinking about for nurses who make up part of the health center program team, like, you know, what are the things that are really important and driving us to get closer to providing better care for our patients. All right, last slide. And so here are my takeaways, but again, I'm really hoping we can talk more, or I can have the privilege of listening in as you talk to each other. Takeaways. First, nurse work is important in so many ways. I don't know if it needs to even be said, but I'm going to say it. But historically, it may have been less visible. And I also think there's a lot of ways you guys were all, you hopped on this idea that the EHR and the technologies that we use every day make that less visible, or perhaps even invisible. Nurses are tremendously important generators and stewards of patient-level data. And so they should be involved in thinking about data governance and also data lifecycle to really make sure that's like an enhanced process that both reflects their work, but it also means they're kind of connecting explicitly to the overall work that and whether that be quality work, you know, as it's defined by both sort of external and internal drivers. So that is my small piece, relatively small piece. And I'm gonna, I think we're gonna take questions at the end of the next presenter's piece, but I definitely appreciate and look forward to questions here. And then this is just some contact information if you wanna reach out separately.
Emma, thank you so much. Yes, please, we welcome you to put questions into the chat. Before we get to our question and answer out loud period, I'm gonna hand it over to Mariah from the Colorado Coalition from the Homeless, and going to share with you some incredible direct experience as the Director of Recuperative Care at the Colorado Coalition for the Homeless. Mariah, thank you so much for being here.
Hi, y'all. Thanks. Yeah, it's like there was a missing camera problem earlier, so sorry for hopping on a little late, but good to see everyone. And Emma, thank you. That was really great. I'm a registered nurse, so I'm a nurse, and I'm also a data nerd. And think, you know, that we can't improve anything we can't measure. So I'm always really excited to get to learn more about topics that involve kind of measuring the work we do and then being able to demonstrate it. In Denver, at Colorado Coalition for the Homeless, we have a recuperative care program. There's a picture right there. And then Katie, I don't know, I know you're doing the slides, so you can just move forward when you want. We opened up our newest iteration of recuperative care in February of 2023. CCH had been doing respite care, medical respite care, recuperative care on some level for about 20 years. In a standalone building that we had over off West Colfax that we own, and then also in shelters. So we've done recuperative care in both our own space and then shared spaces with other orgs. Our newish program, we're a toddler now, has 70 beds where we provide 24/7 clinical access care. We actually just got certified by NIMARC. That's coming. We're very excited about things like that. Right now, this year in 2025, we're going to see over 800 different individuals. We also will probably see closer to 830 patients. We see about 30 folks that will come to us a few times throughout the year. We will be supporting over 2,000 referrals. We take referrals every day of the week, and then we also do intakes every day of the week as well. Our integrated health model mimics the integrated health model that we have at Stout Street Health Center. I'm standing in there right now. It's a federally qualified health center, and that integrated model has primary care, nursing, behavioral health, psychiatry, dental, pharmacy, case management, and peer support specialist. The respite recuperative care program has always been nurse-led and managed, and I'd say that that is still true. Nursing is one of the roles that we schedule 24/7. We do that with LPNs and RNs as well, so that our clients kind of have access to clinical support regardless of what time of day. So in addition to providing that clinical support via an outpatient clinic that we have located inside the program, we also do room and board, safe space for folks to have their hygiene needs met. They have their own assigned bed, they have a locker. We also have programming and activities. So every day of the week, throughout the day, there are art projects, music, sound bath healing, crocheting. We really kind of try to approach health in a very nursing, holistic way that looks at the entire individual as a human that needs connection and not just focuses on medical needs. We provide hospitals in the Colorado community with a safe discharge option. The hospital systems in Colorado, there are 6 main hospital systems, and we're actually partnered with all of them. We're also partnered with a small hospital system in Boulder, Colorado, located outside of Denver. And so that, in addition to our city partnership, means that all 70 of our beds are actually spoken for with a bed reservation MOU that we have. We do take other referrals on occasion from shelter systems, outpatient clinics in the community, kind of our outreach team, our own internal CCH team, but our focus is really to provide folks with a safe discharge after a hospitalization. So I will kind of get into the nursing portion now about what's unique about our program. So like I said, we have nurses that are scheduled and work for us 24/7. One of the big components of nursing in our program is our intake process. So the form you see on the right of your screen is the form that everyone does to kind of access our program. Sorry, the chat popped up, but I'm gonna kind of keep continuing. I can also take questions at the end. So this is a HIPAA compliant online form. It comes to our nursing team, and a registered nurse is the individual in the role that goes through all of our intakes and referrals. They go through the information on the form, and then they start working care coordination to reach out to referral sources, primary care provider. They go through hospital system charting, and they kind of look to see if our program is going to be able to meet that acute medical need that that individual has. We are able to pull all of the referral information into an Excel sheet. It's an online kind of simple database form on the back end. And so we're able to sift through and keep manual track of quite a bit of information for clients coming in and the sources that are sending referrals to us. The way that our nursing team works is everyone that is a nurse works in multiple roles. So all of them are cross-trained on this process for referrals coming in, triaging through the needs of those referrals, going through electronic medical records that the client has, that our nurses have access to. They determine eligibility. And then those same nurses are also cross-trained in intakes in the program. So the actual initial assessment and visit when a client gets here. And then we also have all of our nurses work on the floor. So that's care coordination, discharge planning, chronic care management, education, and wound care. We have an EMR at CCH, and I think my colleagues talked about that in a prior presentation. So we use NextGen, and it is set up kind of as an outpatient EMR. Everyone that is client facing in our program documents in our electronic health record system and can access client information. We also need to be able to give information to our referral sources and look at outcomes of the program. And so that's where the nurses really piece together, taking the information from the referral process, the intake process, what occurs during a client stay, and then being able to assess whether or not it was a successful stay or we help meet an outcome. And then we give that information to hospitals. So we provide quarterly data to hospitals about the referrals that they send us, the bed use or occupancy rate, or sometimes called a fill rate at the hospital, length of stay, discharge location. We in Colorado have the Choreo, which is kind of the regional entity that manages the health exchange information. We are working with them to be able to get information on 30-day readmissions. So our end goal, our ideal state is to be able to figure out when we see a client in recuperative care, if they've readmitted to the hospital within 30 days of discharge. Right now, we manually track that within the program, within our length of stay. And our data actually shows us that our program is closer to 11% for a readmission rate compared to 17%, which is kind of a national readmission average rate. I think one of the critical things about registered nurses in our program and the fact that they work within all of these roles is there's this kind of seamless understanding of what our program can do for someone. And so when they are looking at a referral, since they work in the program and they do the wound care and they help individuals navigate around the building, they're able to ascertain on paper before they talk to someone, typically if our program is going to be a fit. They're also able to talk to that client and answer questions about what the program's like and what kind of needs we're going to be able to meet. And that has really reduced our rate of folks that come to us for very short lengths of stay. We also, so much of the work we do in recuperative care specifically is not related to kind of the acute medical need, but it's related more to the social determinants of health or the community building we're trying to do, or meeting other sort of needs that are more behavioral or emotional. And that's another reason our kind of nurse-focused way that we staff the program, that's our core group that manages everything, is able to hold everything together as well. That might be my last slide, actually. I think that is it. It was a quick presentation, so.
Thank you so much.
Thank you so much, Mariah. We do have time for questions and we want to do those for sure. I am going to, just a slight change of order, I'm going to launch the poll now. I heard from a few people that they had some issues the last time, so I want to give us a chance to troubleshoot it while we are doing the question and answers. So just going to do that as we're chatting.
If folks have questions, you can put them in the chat or